Hi friends, today we are going to learn about brachial plexus. Well, brachial plexus is actually a plexus of nerves that are situated in the axilla and the posterior triangle of neck, which is related for supplying muscles of the upper limb and some muscles of the trunk. With this connection with the sympathetic trunk, it has also pseudomotor supply to the sweat glands of face, pilomotor supply to the erector pili muscles, and vasomotor supply to the blood vessels. Brachial plexus, as I told, is located partly in the posterior triangle of neck and partly in the axilla. Brachial plexus actually forms from the ventral ramayo C5, C6, C7, C8 and T1 spinal nerves. The roots are depicted here C5, C6, C7, C8 and T1. The nerve roots coming out from C5, C6, C7 and C8 and T1 are here. The C5th and C6th roots united to form the superior trunk or the upper trunk. The C7 rootlet continues as a middle trunk and C8 and T1 united to form the inferior trunk. So these are the trunks. Now, the superior trunk, middle trunk and inferior trunk. The superior trunk gives off an anterior branch and a posterior branch. Similarly, the middle trunk also gives an anterior branch and a posterior branch. The inferior trunk also supplies a superficial posterior branch and an anterior branch. What we could see here is that the posterior branches of upper, middle and inferior trunks unite to form what is known as the posterior cord. So this is actually the posterior cord of brachial plexus. Now, the anterior trunk of the anterior branch of upper trunk along with the anterior branch of the middle trunk united to form what is known as the lateral cord. So this is the posterior cord, this is the lateral cord, and the lower trunk continues down as the medial cord. So the brachial plexus has actually three cords: the lateral cord, the posterior cord and the medial cord. Now, the lateral cord gives up a division. Similarly, the medial cord also has a division, which both unite to form a nerve. And here we could see actually the shape of an M. This is actually the stretch framework of brachial plexus. Now we can deal with the branches of the brachial plexus. We know we have three cords: lateral cord, posterior cord and medial cord. The nerve that is directly coming from the lateral cord is called musculocutaneous nerve. Musculocutaneous nerve. This nerve that is in the middle plane is called median nerve. See, median nerve was called two rootlets or two tributaries. They are one is from the lateral cord and one is from the medial cord. So we could tell that median nerve is shown by a lateral root from the lateral cord and by a medial root from the medial cord. This nerve is actually the ulnar nerve. And what about the posterior cord? The posterior cord gives off two main branches. This one is a radial nerve and this one is a axillary nerve. The radial nerve and axillary nerve. If you want to look detail about this brachial plexus, we have to add about some more nerves. They are the C5, the C4 segment also supplies a small tip to the C5th rootlet, and from the C5th rootlet arises another nerve which is called as dorsal scapular nerve. Dorsal scapular nerve. Okay. Now, the C5, the C6 and the C7 nerves actually unite and form a long nerve which is running downwards. From the picture itself we can say it is a long nerve, it is the long thoracic nerve. Long thoracic nerve, dorsal scapular nerves. Now here, this is actually the superior trunk, the middle trunk and inferior trunk. From the superior trunk arises another nerve which is called the suprascapular nerve. And another nerve which is coming down is called the nerve to subclavius. Friends, you must observe this point. Here what we see is there are two roots C5 and C6 uniting to form the superior trunk of brachial plexus, which splits into form an anterior and a posterior division, and from there are two nerves arising, one is the suprascapular nerve and the nerve to subclavius. So here we have a union of 6 nerves and this point is known as Erb's point, E-R-B-S, Erb's point. Now coming to the other branches of the lateral cord, the first branch is the musculocutaneous nerve, the other branch is actually the lateral root of median nerve, and there is one more nerve from here which is actually the lateral pectoral nerve. Now, the other nerves of the medial cord are, from the medial cord there will be a nerve which is called medial pectoral nerve. We see the lateral pectoral nerve in the lateral cord, so we have a medial pectoral nerve here. After that, we will have two nerves. They are, first one is called medial cutaneous nerve of, the first nerve is called medial cutaneous nerve of arm in the order, and the next one is called medial cutaneous nerve of forearm. Medial cutaneous nerve of forearm. So medial nerves are medial pectoral nerve, medial cutaneous nerve of arm, and the medial cutaneous nerve of forearm. The next nerve is ulnar nerve, and the fifth one is the medial root of median nerve. So these 5 nerves form the medial cord, these 3 nerves from the lateral cord, and this posterior cord is actually formed by 5 nerves. The first one is called upper subscapular nerve, next is called lower subscapular, and the third one is called thoracodorsal. We can show the posterior cord here. It divides into a radial nerve and an axillary nerve. Then the first branch is called upper subscapular nerve. Then we have a lower subscapular nerve, and then we have is called thoracodorsal nerve. Now, how to remember these things easily? We can remember by a small mnemonic. The posterior cord can be remembered by ultra, U-L-T-R-A. U is actually for the upper subscapular nerve, L is for the lower subscapular nerve, T is for thoracodorsal nerve, R is a radial nerve, and A is axillary nerve. The branches of the medial cord can be understood by remembering that there are 4 nerves starting with the M, and there is a U nerve. It will be medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, ulnar nerve, and the medial root of median nerve. So this is actually the brachial plexus in the line that we can look at the detail about the cords of the brachial plexus. First will be a lateral cord, then we will have a medial cord, then a posterior cord. So the nerves in the lateral cord, you can just remember. First one, the nerve coming directly will be the musculocutaneous nerve. Then we will have the lateral pectoral nerve. Then we will have the lateral root of median nerve. So, you see that all the 3 nerves in the lateral cord have a single root value, which is actually C5, C6, C7. Don't forget this. C5, C6, C7 is a common root value for all the 3 nerves in the lateral cord. Coming to the nerves in the medial root. So in the medial cord, in fact, they will be the nerve starting with them. Medial pectoral nerve, then medial cutaneous nerve of arm, then medial cutaneous nerve of forearm, then we will have ulnar nerve and the median root of medial nerve. So the root value for all the nerves in medial cord is actually C8 and T1. But there is a small exception here. It is actually the medial cutaneous nerve of arm. Medial cutaneous nerve of arm gets a small tick from the T2 segment. It is actually called intercostal brachial nerve, and hence the root value for medial cutaneous nerve will be C8, T1, T2. Keep a note of this. Coming to the roots of the posterior cord, it is understood by the cord ultra. They will be upper subscapular nerve, lower subscapular nerve, then we have thoracodorsal nerve, then we have a radial nerve and axillary nerve. In this actually radial nerve has all the 5 roots. They are C5, C6, C7, C8 and T1. Thoracodorsal nerve has C5, C6 and C7, while all the 3 rest nerves have C5, C6, C5, C6, C5, C6 rootlets. So this has to be by hearted. It is simple. Keep a check on this medial cutaneous nerve of arm and radial nerve, because radial nerve has all the 5 roots of brachial plexus. Similarly, if we check here, we have median nerve. The lateral root of median nerve is formed by C5, C6 and C7, and its median root is formed by C8 and T1. So we can also say the median nerve is also comprising all the 5 roots of brachial plexus. So now we look at the clinical aspects of brachial plexus. First one is the total injury. The damage to the brachial plexus as a whole will cause paralysis of serratus anterior muscles, rhomboideus muscles. Also we are told that brachial plexus, the T1 ventral rami has supplied to the sympathetic chain. So the total injury to brachial plexus cause sympathetic problems, which are summarized by a syndrome known as Horner's syndrome. Horner's syndrome is due to damage to the ventral rami of T1 spinal segment in the brachial plexus. The features are, first one is partial ptosis or the paralysis of the Muller's muscle, leading to the drooping of eyelid. Second one is miosis or constriction of pupil due to paralysis of dilator pupillae. Next, we will have anhidrosis or absence of sweating due to damage to the pseudomotor supply. We will have flushing in the faces due to vasomotor problems. And finally, there is loss of ciliospinal reflex. Ciliospinal reflex is actually the constriction of pupil by the pinching of the nape of the skin of neck. These 5 features are actually seen in Horner syndrome, which is caused by damage of the T1 ventral rami or spinal of the brachial plexus. Now we will look up what happens if there is injury to the upper trunk of brachial plexus. Guys, do you remember the S point that I told before? Check. C5 and C6, the rootlets unite to form the upper trunk, which divides to form an anterior and a posterior division. There are 2 nerves coming out from here. One is nerve to the suprascapular nerve and a nerve to subclavius. Suprascapular nerve and nerve to subclavius. There is an anterior division and a posterior division. So this point is actually the Earth's point. In forceps delivery, when the baby is taken out using a forceps, there occurs damage to the upper trunk of brachial plexus, and we have a clinical feature which is known as porter's tip or waiter's tip or policeman tip. The typical features in porter's tip are adduction and medial rotation of arm, adduction and medial rotation of arm, followed by extension and pronation of forearm. The muscles that are causing adduction is the paralysis of deltoid and supraspinatus, and by the overactivity of adductors of the upper limb. The muscles causing the problems in medial rotation is actually the paralysis of infraspinatus and teres minor, and the overactivity of medial rotators. Muscles causing extension is actually the paralysis of biceps brachii, brachialis and brachioradialis. Biceps brachii, brachialis and brachioradialis, and the overactivity of extensors of the upper limb. And the pronation is actually due to paralysis of supinator and biceps brachii, and overactivity of the pronators of upper limb. Suppose what will happen if there is an injury to the lower trunk of brachial plexus by a fall from a height or to the presence of a cervical limb. Then we will come across a condition known as Klumpke's paralysis, where the lower trunk formed from C8, T1 dividing into two branches get paralyzed. Here, it may be due to fall from a height or due to presence of a cervical limb or the hyperabduction of the brachial plexus of the arm, upper limb. The typical clinical feature in Klumpke's paralysis is a complete claw hand. Complete claw hand. So, complete claw hand is represented by the extension of the wrist with the hyperextension at the metacarpophalangeal joints and flexion at interphalangeal joints. So this is the typical representation of a complete claw hand, where there is wrist will have hyperextension, then the fingers will have at metacarpophalangeal joints it will be hyperextended, and at interphalangeal joints it will be hyperflexed. So this is the clinical feature in Klumpke's paralysis, as there is damage to the lower trunk and damage to the T1. Of course, there will be damage to the sympathetic plexus supplied by the T1, and which can also causes Horner's syndrome that we explained. And the final clinical application related to brachial plexus for our knowledge is giving brachial plexus nerve block for the surgery to the upper limb. The anesthetic solution can be introduced to the brachial plexus, to the supraclavicular triangle in the posterior triangle, and it causes anesthesia to the muscles and loss of sensations. So the four clinical features are: first one is Horner syndrome in total injury. The second one Ehr's palsy or policeman or waiter's tip. Third is Klumpke's. See, and the fourth one will be nerve block. So that sums up the brachial plexus, and you must know how to draw the brachial plexus. It will rise from C5, C6, C7, C8 and T1. The nerve roots coming. We will have 3 roots. The 5 roots united to form 3 trunks R, T, D, C, root trunk division and cord. The trunk will have 3 posterior divisions to form the posterior cord. Then the anterior divisions will unite to form the median, the lateral root. Then we will have this medial cord formation. So this is a musculocutaneous nerve. This is a median nerve, and this is the ulnar nerve. This will be the posterior cord with axillary nerve and radial nerve and related to the X point. And this is all about brachial plexus.